name is Paul Strangis. I'm the Assistant Director for Opioid Stewardship and Drug Diversion at UI Health.
My name is Xenia George. I am the Perioperative Pharmacy Services Coordinator here at UIH.
My name is Matt Gimbar. I'm Senior Associate Director of Pharmacy over Operations here at the University of Illinois Hospital.
Fresenius did provide a waste analysis that helped, one, confirm some of the previous analysis that we had seen. It did offload some of the work that me or my team needed to do and identify ready-to-administer syringes or available products in the marketplace. The analysis was very thorough and helpful to identify specific units, specific areas that could benefit from those products. It was helpful for us to confirm that this was a direction that we should go in. So we conducted a waste analysis at the hospital, primarily because we wanted to try to identify those opportunities where we could implement unit of use or ready-to-administer syringes.
One of the areas that we had identified specifically was in the perioperative space of reducing waste, especially with post-op areas where nurses had a higher incidence of wasting medication. So we had started initial discussions about ready-to-use syringes at that point.
In a role such as mine with operations, the thought to convert to a ready-to-administer syringe or anything that involves medication distribution comes down to how it's going to impact your staff, and then ultimately how it's going to impact your customers, whether it be your direct customers, nurses and providers, and as well as your secondary and ultimate customers, your patients. So what can we do to help make their experience easier? What can we do to help take care of our patients more efficiently? And what can I do to help my staff complete their day-to-day work more efficiently?
One of the primary drivers for selecting Simplist syringes was the concentration and availability of products that we needed within our hospital system. Not a lot of manufacturers make a lot of the concentrations that are needed, especially in the perioperative space. So having the right concentrations that is ideal for our anesthesia team was something that we looked for when we were looking into ready-to-use syringes.
I think as an institution, especially if you're in an operations role, you have to consider, cost implications here when it comes to RTA syringes and how it's going to impact our end users and patient care. It was a no-brainer.
One of the reasons we looked at waste at our hospital was based off published literature and a primary analysis of time and motion study published by a pharmacist, John Hertig, that identified opportunities to reduce waste and reduce time that nurses spent documenting waste at a hospital. And so we conducted our own analysis here, looking at all of our Omnicell cabinets, all of our doses dispensed, doses administered, and doses wasted across the whole hospital at a unit by unit level, and identified opportunities where there were units that did end up documenting or administering doses that were available in ready-to-administer syringes in the market. The waste analysis provided a lot of great insights for us. We identified, for example, if we're looking at most common doses administered for hydromorphone, we found that 0.2, for example, was one of our most common doses administered in many units, and providing larger syringe sizes meant that a larger quantity of those syringes were being wasted with each one of those administrations. And so we were able to identify specific units that would be a good candidate for these ready-to-administer syringes. Key stakeholders when we decided to explore bringing in more unit of use and ready-to-administer syringes were within pharmacy. We had to obviously talk with our purchasers and make sure that there were adequate supply of products and available from our wholesalers. We had to talk with our pharmacy operations and make sure that we were able to identify where these syringes were needing to be distributed to and assigned to throughout the whole hospital. Our pharmacy informatics team needed to make sure that adequate build was in place to make sure that ordering, dispensing, and all the available information systems were able to talk with each other so that these products were dispensed at the right time for the right orders. And then obviously our partners on the units and the floors that were going to be using these products needed to be informed and aware of these changes coming, whether that be nursing or anesthesia colleagues and partners as well.
In a perioperative area, we got our PACU nurse involved and also our leadership within the anesthesia team to look for the right product, the right dose that would be ideal for these settings, as well as informing them what would be the best way to reduce waste in these areas.
When speaking with nursing colleagues, we discussed that we were going to be bringing in a new product in a ready-to-administer syringe for nursing units that were administering doses that were currently being drawn out of vials. Nursing was more than happy that the medications were going to be available in a ready-to-administer syringe that would only require putting a needle on or administering through the luer lock.
In the perioperative space, the PACU, we are discussing more so about how the waste needs to be reduced, how much waste is currently occurring, and we continue on to discuss how this will be beneficial on the nursing side. When we are talking with anesthesia leadership, we're talking about efficiency within a case, the time needed to prepare for a case, as well as discussing what would be ideals within an anesthesia environment.
There was healthy discussion about what the changes were and the needs for those changes. I think from the anesthesia and nursing perspective, there wasn't too much resistance to bringing these products on, just more conversation about what they were and making sure that all questions were answered. And from the pharmacy perspective, making sure that product availability was reliable, and making sure that medication safety issues were primarily addressed.
There's always going to be some level of resistance with some providers when it comes to any kind of change you want to make. But again, a lot of times it's having those kind of relationships and understanding what is their need and what will make their jobs easier. And if efficiency comes into play, a lot of people will not be resistant to those kind of changes. When they are doing waste at an Omnicell, it requires another nurse to witness the waste versus when they are removing a medication from the Omnicell, they do not need another provider or another nurse to remove that medication. When waste is not correctly documented, there is even a longer process that the nurses have to go through to resolve those discrepancies that occur. Overall, having smaller unit size syringes available to them or smaller unit concentrations that are more appropriate for the setting that they're working in will help in overall reduction in time.
So I think the most important thing for any institution when you're making some kind of wholesale change is to try to prepare yourself as much as you can in advance of go live. You have to try to think of all the different angles and set yourself up for success in advance of the day of go live. So one of those things is making sure that as many of your own staff as well as staff outside of the pharmacy department is aware of what's happening. Nursing staffs, as well as providers, anesthesia, that sort of thing. Trying to work with those key opinion leaders, your key stakeholders in those areas to help get that information out. When we talk about the pharmacy, I think we have to go a little bit deeper, not only just educating our staff, but then we have to prepare our automation systems. A lot of that stuff is going to involve doing some analysis of your automated dispensing cabinets. Do I have the right size bins? Do I have the right amount of bins? Looking at the data for usage. So you obviously want to make sure you set up your automation in a way that it's going to be conducive to the process you have ongoing with how many times you touch those machines in a day. Am I going to be able to provide the amount of drug that I need to? How do we adjust maybe our ordering patterns to prepare for that, bringing in the unit of use so we can have those ready to go, identify who's going to do that. You'll need to engage probably your IT team or your frontline staff pharmacists who are going to be able to look at that list and make those changes once we convert the products, kind of developing that timeline to make sure that things are kind of happening sequentially in a way that's not going to impact the patient care that's continually ongoing at your institution.
When it comes to stocking or figuring out where to stock syringes within our dispensing system, we have to look at space. One of the benefits with Omnicell is they do have multiple different types of syringe dispenser systems, which makes it ideal in saving space when it comes to syringes. For training, we utilized materials for all of our end users. Whether it's nursing or anesthesia providers, everyone received some form of training. When we switched to RTA syringes, we did utilize sample syringes, provided them with our educators so that within nursing, there would be education that can be done. Within anesthesia, they were not new to some of the syringe types, so there was not a lot of hands-on demo education that needed to be done. We did a lot more of email-based education to all the providers, which included what our previous RTA syringe was, what our new syringe was going to be, the changes in concentration, and also informing them the reason behind this change. Our two buildings were using two different concentrations. This would have made a uniform concentration across our perioperative area.
As far as challenges that we saw during implementation, it really did come down to making sure that our Epic build matched Omnicell and that the right product was being verified for the orders and that the right product was going to be dispensed for orders. We did experience an issue where currently verified orders needed to be switched over, and so that just required some coordination with our clinical pharmacist and pharmacy operations team to re-verify any orders so that it would point to the right dispensing product. From the pharmacy end, once we turned the dispense logic live and we needed to go live with it, there was maybe a day or two where we had to figure out, okay, these certain units, or we're seeing issues where this product's not being dispensed the right way, and we would have to work through a couple of logic issues with the dispense criteria that we had built out, but those were resolved relatively quickly. And then intermittently, product availability might change, and so we need to shuffle around product. And so those things come up intermittently like any drug product and drug shortages these days. Operationally, I think in some areas they were used to higher concentrations and had developed workflows that relied on those higher concentrations to administer certain doses over a series of administrations. For example, in our recovery room, nurses might have been used to pulling out a higher dose, but administering smaller doses over time. When we switched out to lower doses, there were some concerns that the workflows for the nurses would need to change. But persistence and making sure that we were providing clear reasons why we had to switch to these unit of use products to reduce opportunities for waste and reduce risk of diversion, and to keep things as consistent as possible so that we weren't flipping between products and flipping between formats to reduce safety issues, was one of the key things we just had to keep reiterating, and we kind of had to stay firm on that line a little bit.
I think the problems will occur if there was never conversation or education prior to the go live. But if you have those kind of relationship with the nursing team, with the anesthesia team, and concerns can be aired out prior to go live, it makes it a seamless transition.
Almost immediately, we found that controlled substance discrepancies involving controlled substance waste reduced dramatically when we weren't requiring waste because they were administering drugs in unit of use. The volume of drug product that we were ordering stayed relatively consistent because, again, we were dispensing a larger volume of drug to administer the same dose. So the syringe number or the vial number that we were dispensing stayed relatively the same. We just were wasting less. And so on my end, the results were pretty impressive with the number of discrepancies we reduced. The number of times nurses were being asked to waste drugs was reduced significantly, obviously. And then my team reviews all controlled substance transactions and needs to follow up with nurses when controlled substance waste isn't documented. And so personally, my team's requirements and time was reduced greatly because they didn't have to follow up and chase down discrepancies or close out discrepancies and document them as undocumented waste or inaccurate waste. And so we saw, a tremendous amount of change and time spent on our end trying to track these things down.
We're definitely seeing a reduction in waste. It's going to lead to efficiency for both the pharmacy team, efficiency on the floors, taking care of our patients. It allows our staff and our providers to spend more time doing the work that they're really charged to doing, and that's focusing more on the patients versus doing some of the back end work with handing syringes in and doing reconciliation and that sort of stuff. The focus gets to be on what it needs to be in the healthcare, which is our patients. We want to decrease the amount of discrepancies that we're seeing. At least that shows a good trend to having less chances for diversion happening when you're using those unit of use type syringes. We saw that here. We did see a decrease in the amount of discrepancies just because we're using whole syringes, whole amounts of doses. So now you don't have those partials that need to be documented or returned. I think a lot of discrepancies stem from the documentation piece of it.
For advice for other hospitals, from my perspective, I think the waste analysis and looking for opportunities to implement more unit of use products is one of the starting blocks to having these conversations and having that data to start with so that you can reflect back on it and look to see how much you've reduced waste events. And if you are tracking discrepancies related to controlled substance waste, having that data before and after to compare to will help have those conversations should there be any questions about how the implementation is going or to justify unit of use syringes or unit of use products. I think having those conversations with pharmacy operations, key stakeholders within the pharmacy that understands how it might impact operations, order verification, distribution of products, how orders are being verified and then dispensed from ADCs.
After the initial communication, you want to follow up with those areas. You want to follow up with the nursing units. You want to follow up with the providers to say, hey, did everybody understand how this went? Did everybody run into any issues? Sometimes people are not forthcoming with challenges that they had, so you want to make sure you're the one going out there and soliciting information, soliciting feedback after you go live.
Having as many of those conversations up front are going to help with reducing any issues or problems that might arise after go live. And then from nursing standpoint, I think communication was key, making sure that they understood what was coming and that the syringes were familiar to them. The products that we implemented were familiar, just in a different dose or a different concentration. I think helped smooth any concerns or questions that they might have had, or led to more acceptance of, oh, this is something that we're familiar with. This is something we've seen. It's just a new product, a new color syringe.
Advice for other hospitals would be that look at the data for where there is waste. There will be a significant difference that you will see when it comes to waste analysis, especially for controlled substances. Within our perioperative space, we've seen a reduction in how much waste comes back from anesthesia for us. And that also makes it a time saver for our pharmacy staff on what they need to co-sign and what they need to resolve out as well.
The biggest thing is to just try to do all your legwork, try to have everything in place and control the things you can control well in advance. That makes the go live part that much easier when, if you do run into some of those wrinkles or some of those hurdles that may not have been anticipated, you have the time and resources to be able to address them quickly and not have to kind of, fly by the seat of your pants fixing problems to start. Obviously, there's going to need to be an evaluation beforehand to make sure this change makes sense. But then when you do make the change, you also want to continually evaluate it to make sure you got the biggest value, the biggest bang for your buck, if you will, or the biggest change operationally and physically and customer service. But then if there is further opportunity, you want to make sure you can garner that, and then you actually want to make sure the change you put in place is going to be successful.
Fresenius was very supportive throughout the whole process of identifying opportunities to implement ready-to-administer syringes and unit of use products, from helping provide and help supplement the waste analysis that we had performed to identify these opportunities, through implementation, checking in to see how the implementation had gone, discussing accessibility of the syringes, pricing, availability in the marketplace, I think was another conversation we had that was helpful.
Our colleagues at FK have done a great job helping us through this process, helping us see some of the opportunities in front of us. We appreciate that and look forward to partnership going forward.